Right, ladies and gentlemen, a very, very warm welcome to the Nordic Council of Ministers. I'm Maria Graciev, I'm the director in our office here in Estonia, and you are also very welcome to our very first panel of the day, and the very first panel of this year's Arvamus Festival. This panel has some bees as well circling around us. That's a healthy sign. This is a really interesting panel, and the idea of actually organizing this panel came out of last year's conference and a report that the Nordic Welfare Center issued. This is one of our institutions based in Stockholm with also presence in Helsinki. They have released a really interesting report about preventing dementia. There is a lot more you can do than you would think. My own takeaway from that report and that conference was just that. Going there thinking that, well, if and when dementia hits you, there isn't much you can do. And I was incredibly happy to be proven wrong. There are things that you can do, and that's exactly what we are going to talk about today. Dementia is one of those things that I think most of us would come across in one way or another during life. Maybe we have grown up with, a grandmother or a grandfather who has been suffering from this or something else, but it is a widespread phenomena that really deserves more attention. So we're going to explore a bit more about what can actually be done. And over to you, Chris, as a moderator, and to our fantastic panel, and a very warm welcome.
Thank you. Thank you for the good words for the beginning. I'm Chris, I'm the moderator, and you definitely have a question why I have to moderate this, or why I have agreed to moderate this, because dementia, Alzheimer dementia, I have a own personal contact, as my mother was diagnosed with Alzheimer dementia at the age of 73, now already 10 years ago, and she lived with the diagnosis for more than 6 years. I went through the whole journey from the diagnosis to the end, and at that time there was no any discussions in any level about the possibility to prevent or stop the progression or whatever. When you got the diagnosis, then it was kind of the end. And then at that time there was also very few possibilities to find information and support, and in 2016 the NGO Life with Dementia was created. I was the first joint member, and today I am the board member of this NGO. We created the NGO with a mission to make life better for dementia patients in Estonia. Since this almost 10 years, again, we have achieved a lot, but still the mission in the air, and there are much more things to do. With this debate in today's festival, I strongly believe and hope that dementia will be not just a scientific or medicine problem, but will turn into something much bigger, to be political, societal, and a community challenge, because I hope at the end of the discussion you will understand that everything is, or at least something is in our hands. And it's not just a personal problem, because with our aging population, the number of people living dementia is growing year by year, and as the estimate today is that there are around 20,000 people living with dementia it will be doubling by 2050. And also in Europe, there have been done studies to calculate what is the cost of a person living with dementia, and the range is from 8,000 euros per year to 70,000 euros per year. It's becoming also a burden for our social system. But with saying that, I'm really thankful for the panelists, and we are here collected a group of high experts, and I would like to give the floor for them. Please introduce yourself and also ask a first question. Why is dementia prevention important to you, either than professionally or personally? Jaak, could we start with you? No, just talk.
Good morning, everybody. I'm a medical doctor, and I've been working in geriatrics in Germany for more than 10 years. I have seen about 5,000 to 6,000 geriatric patients. That means the people who are about 75 years and more. And I have to make the first remark about dementia. Dementia is an umbrella, and it does, for me as a doctor, include several diagnostic units. And within this umbrella, there are diagnostic units we can change something, and there are something we cannot prevent. For example, Alzheimer's disease is a neurodegenerative disease, and we cannot prevent it, especially the early onset of Alzheimer's disease. Also, we cannot have any influence on the Lewy body dementia, Lewy body disease, but there is a wide spectrum of other cognitive disturbances, which although are collected under the umbrella of dementia, and that is what I, as a doctor, can speak about. I can never give you a message that Alzheimer's disease is preventable. That's my introduction.
Thank you. Pia.
Yes, hello. My name is Pia Nevala Westman, and I am a senior advisor at the Nordic Welfare Center in Finland. We have two offices. The other is located in Stockholm. I'm senior advisor in the area of public health, because that is an area that we cover within the institution. And the institution is a part of Nordic Council of Ministers, Council of Health and Social Politics. But I'm also the coordinator of the Nordic Dementia Network that gathers all the Nordic countries with specialists from the public agencies and from ministries, but also from national competence centers. So I linger really in all these topics and issues concerning dementia. We got a project from the Nordic Council of Ministers to map all the activities that are done in the Nordics concerning dementia prevention, but also like policies and so on. So this was the starting point actually to work on the dementia prevention topic. For me, this topic is very inspiring. I'm also a relative to people with different dementia diagnoses. So I have the personal experience of that. But since I also work with policy questions and politics, I know that dementia is a huge challenge to become. It is already, but we are going to double up the amount of people with dementia, and to be able to give good health care and care for those with dementia, then we also need to work on the health promotion and the prevention part of it that can delay dementia in some people, but also maybe that you can preserve some cognitive capacities for a longer time if you get the right support.
Thank you, Pia. Janika?
Hello. My name is Janika Paal and I work as a nurse in memory clinic at Viljandi Hospital. Memory clinics are becoming routine medical units around the world. They can be a part of primary care institutions or hospitals. And memory clinics also have an important role to play in reducing the societal and personal stigma that can accompany neurodegenerative disease. And the aim of memory clinics worldwide is to detect Alzheimer's disease and other dementias at an early stage. For me, this topic is very important also because my own dad died with vascular dementia 15 years ago. I have noticed that still many people, if they meet the first symptom of dementia, they often attribute those symptoms to normal aging, and this view should change, I think.
Thanks. Merit?
Hello, everyone. My name is Merit Kudavita. I come from the North Estonian Medical Center. I'm the head of neuropsychiatry and the general psychiatric department. Well, 2,000 years ago, the Romans said, mens sana in corpore sano, a healthy mind in a healthy body. As a psychiatrist, I see this ancient wisdom confirmed every single day. True mental health requires attention to the whole person. While we're trained to diagnose and prescribe, we're often overlooked the broader picture, how lifestyle factors like nutrition, movement, social connection, and sleep shape outcomes. I can prescribe effective medication for schizophrenia patients, but if my patient is isolated, inactive, malnourished, or unsupported, recovery is really fragile. Relapses become more frequent, negative symptoms worsen, the risk of dementia increases, and overall life expectancy declines. Just this year, I attended the American Psychiatric Association annual meeting in Los Angeles, and I heard a very inspiring speech by Dr. Dean Ornish. It was an awards speech called A Unified Theory of Lifestyle Medicine. His message was really clear. Lifestyle changes don't just support health. They can prevent, treat, and even reverse both physical and mental illness. So this is why we're here today, to help shift awareness and make action. Healing happens not only in the clinics, but in the choices we make every single day. Let's be a part of the change.
Thank you. I think before we move forward, we need to maybe open some terms. As Jaak also started to describe dementia syndrome as an umbrella, there also have been said about memory disorder or cognition, minimal cognitive impairment, prevention, brain health. So could you start, Merit, with the cognition and minimal cognitive impairment and how this is, are they connected to dementia syndrome or how they connected?
Okay, it's a tough question, by the way. Well, cognition is a very broad term and used very differently amongst different professionals. So just in case to get it right, I noted down one of the main cognition terms as written in psychology textbooks. Cognition is a broad term which has been traditionally used to refer to such activities as thinking, conceiving, and reasoning. Most psychologists have used it to refer to any class of mental behaviors with underlying characteristics of an abstract nature involving symbolizing, insight, expectancy, complex rule use, imaginary, belief, intentionality, problem solving, and so forth. While the term is typically applied to mental activities in general sense, individual thoughts, ideas, or pieces of knowledge are also sometimes just referred to as cognition. So when we're talking about cognition, we're not talking just about diseases or anything like that. We're talking about the activities of thinking. Well, and the other term, MCI, or mild cognitive impairment, well, this term was first coined by the North American researchers to identify people at high risk of developing Alzheimer's disease, also known as MNCD, a mild neurocognitive disorder. The use of this term is now common in clinicians because we see more and more of patients that have cognitive problems as the population ages. Awareness of the treatability of some forms of dementia actually grows. So, the MCI is characterized by cognitive decline, but critically, the patient must retain functional independence, and the condition is distinguished from dementia syndrome or major neurocognitive disorder this way. So basically what I'm saying is MCI is often defined arbitrary as performance of 1.5 standard deviations below the age and education-adjusted norm on at least one neuropsychological test. But at the same time, where daily activities and living are substantially unimpaired. And there is concern regarding cognitive decline by either the person himself, the memory, the clinician, or the close relatives. So to sum it up, it's the term where we see the cognitive decline, but it doesn't affect the everyday life, and it can't be diagnosed in any way as a dementia. I guess that sums it up.
Annika, could you elaborate on the memory issues related to cognitive decline and to dementia? Can we put the equal sign, or is it just the beginning of the journey? Now you are in the memory clinic, so.
Thank you. The term memory disorder is not narrow also. This is also quite a wide term. This is a general term for any condition that affects memory. It does not necessarily mean progressive cognitive decline or a permanent impairment. It can include some head injuries, stroke, depression, infections, alcohol abuse, and yeah, that's my definition.
Yeah, now we came back to the dementia syndrome and diagnosis. So in the literature, so also in scientific and also popular literature, there are questions in the air when we really can put the diagnosis of dementia. Is it when we see the memory problems or cognitive impairment, or when the person is really not able to perform? Can I have the first slide, please, also? Yeah.
Thank you very much. Actually, as a medical man, I'm very practical. I was just working in Germany. The colleagues asked me to make geriatric work in a hospital for 2 weeks, and there I had a special patient for this occasion. He was a psychiatrist. He was 80 years old. He was living alone. He couldn't get out of the bed. his financial situation was a bit query. A neighbor helped him, and his daughter was also a psychiatrist. And his daughter turned to court and said, my father in this point has dementia. We have to give him a person who takes care of him, that's in German Betreuer, who takes care of him, and it must be established over court whether the patient will it or declines it. Now I come to the patient. He was very intelligent. He had written 2 books about psychiatry. His mini-mental, that is the memory code was 24, that is only mild memory loss. And the question is, if as a doctor, can label the man with the diagnosis dementia or not. And then the German classification has a very good possibility for such cases. They don't have only the F diagnosis, which is dementia, F0, but they also have the cognitive impairment. And cognitive impairment does include not only the mini-mental test, but does include the activities of daily life. It is a summary. If you can brush your teeth, if you can eat yourself, if you can go to toilet yourself, and there is also for physical activities a part of it. It is the Barthel index. And now he doesn't fulfill the criteria of activities of daily life because he doesn't recognize that he cannot be alone. His daughter is absolutely convinced his father needs somebody who takes care of him. The father says, no, I don't want it. What should I, as a doctor, do? Should I label this man, our colleague, the psychiatrist, with the diagnosis of dementia or not? The question remained open for me because the colleagues who are working there permanently came back and I told they have to solve it, although I had already been in contact with a psychiatrist. No, the message is, it is very difficult for single case to decide if somebody has dementia, cognitive disease, and what consequences we as a community should withdraw from that situations. That is my case report.
Thank you. It's becoming even more complicated than I thought. But Pia, could you now open up the even more wider term, the brain health, as WHO has stated that brain health-related challenges are becoming more and more visible, and dementia is on the 3rd place after stroke and migraine. So how this can be all put into the more bigger picture?
Yeah, I think that brain health is really like global health and well-being issue from like a personal global, all your health and well-being. And it's also defined by the WHO as something that affects your health and well-being, and that the brain is a part of the body, and the brain also needs all those basic things to function, as you already mentioned. You need to sleep, you need to rest, you need to be physical activity, have friends, have some problems to solve to keep the brain going. So in that sense, brain health is not so very different from the other parts of the body's health.
The heart health.
Yeah, because what is good for your heart, for instance, is also good for the brain. But something else that WHO mentions is that, of course, during the life course, from the time when you're born, things can happen to you. You can have get brain damages or like accidents and so on, but you can also make life hard for your brain by having a lot of risk factors in your lifestyle, for instance, smoking and excessive alcohol and so on. So my point is that the brain is part of the body, and what's good for the rest of the body is also good for the brain.
Yeah, definitely. But coming now to the stigma that still is around dementia and all those terms we are using with elderly people, although we know, I hope you agree, that dementia is not normal part of aging. Is there any better word to use to diminish the stigma instead of dementia? Now while listening to you, I think that adding those memory problems, minimal cognitive impairment, even confuses the public. So would you agree with me or not? Or what about the stigma? Can we diminish it just by changing the word dementia to some other word? Quick answers from you, starting. Yeah.
I took something with me. I have a good friend who is a philologist. He was teaching at the university English language for 20 years. And I've always told in Estonia it is not so good to to say, my grandmother is dement, has dementia. And I asked him, how many words are there to depict the queeriness of mental health? And you see, there are eight sheets of paper. There are words buffoon, there are words fathead, there are words like Wally, a stupid person, the dictionary does say. And I'm absolutely agree with you that when we talk about our relatives or elderly people, please don't use the word dementia as the first word. Please pick up a very well-known Estonian word, eakas tobu. That was in Estonia. That is my advice. Yeah. Not to be labeling, not to label and to be stigmatic. Yes.
Yeah, I think this is a topic for different discussion. Yeah. I absolutely not agree with you, and this is why we are in our NGO and also in Alzheimer Europe trying to say that the people who are having memory problems, cognitive impairment, dementia, we should say that they are person living with dementia. Because Tobu in Estonia, it also labels, and we shouldn't do it, because this is not just a labeling problem, but this is also a problem that people are not seeking help when they actually need already. This is why we need to be really clear. But coming now to the next question, as also Jaak mentioned that some types of dementia cannot prevent it. So what we can actually prevent, or how we define the word prevention, or what do you mean? Can it be just delay of the onset of the disease, or reduction symptoms, or full avoidance, or slowing down the progression? So Pia has a microphone ready. Maybe we could start from you, that what we actually can prevent.
The Lancet Commission 2024 labeled 14 risk factors that we can minimize or maybe even eliminate during the life course. And I think that the primary prevention is that what we do from birth. We give our kids good schooling, and then we try to avoid lifestyle risk factors for them, for the children and for the young. And then the risk factors actually accumulate in midlife. And I think that raising awareness that it's what is good for the heart is also good for the brain, then we can also risk minimize like other vascular diseases. And the vascular diseases are also the ones who actually contribute to the vascular dementia later. So that is the part that is preventable. And then later on, when you
Can we
grow,
have a second slide, please?
when you grow older,
No, the
then
third one.
for an aging person, very important risk factors are like social isolation, like in the late life. So we can do a lot of things policy-wise to prevent vascular diseases and vascular dementia, but we can also delay the onset. But we have these terms: primary prevention, secondary prevention, and tertiary prevention. So the secondary prevention is when you already have some kind of really manifest risk factors, or even like an MCI diagnosis and so on. So then you can also modify some risk factors. So there is something that you can do as a person or a relative to help your relative, or as healthcare persons to give good advice. But then, of course, it's never too late to have good lifestyle factors that protect your brain. And this is also possible to do in the tertiary phase, when you already have the dementia diagnosis. And we have seen it, we saw it at the conference in Stockholm last year, that there was this lady from Aarhus Kommune in Denmark, where they have this day activity center where they do a lot of cognitive stimulation, social networking, and so on, just to keep these persons going as long as they can and live a good life. Because I think that is also the part of a tertiary prevention, that you can live a good life even if you have the diagnosis.
Okay, thanks.
Okay.
Do you agree, medical doctors, nurse, with the secondary, tertiary prevention?
Well, when we were asking about the stigma before, I think one of the things we should be talking about cognitive decline, because cognitive decline is something very broad. And if I think of psychiatry, if cognitive decline is a common feature across so many psychiatric diagnoses and disorders. For example, probably some of you have heard about the term pseudodementia. We also talk about it. But it refers to dementia-like symptoms, but it can it really appear with severe depression. And the symptoms are reversible with appropriate treatment, including medication, neuromodulation, psychotherapy, and lifestyle interventions, of course. And among these, social connection plays a particularly vital role in the sense of belonging, being heard, accepted, loved, with the supported community and all that. So we're actually, and we know that depression also affects the same regions as dementia. We're talking about the hypothalamus, like different kind of places, hippocampus, all of those regions. So this is already a prevention. When we treat the medical diseases that's supposed to be treated, and this is just not psychiatry, it is also all the somatic diseases. If we keep them under control, then we're already reducing the risks, and they are also set in the risk factors. But when it comes to prevention of Alzheimer's disease, it really doesn't mean full avoidance. More often it refers to delayed onset, reducing risks, slowing progression. Most experts agree. It's like in many chronic results from complex interplay. It's a result of age, genetics, environment, lifestyle, coexisting medical conditions. The current focus in dementia research has actually shifted from identifying risk factors to developing targeted interventions. And this is what Pia was just saying, to get those risk factors there, and if we see the risk factors, then we make action, we do something about it. So we can make those lifestyle changes. And we can't yet fully prevent the underlying pathology, like Jaak said, especially those with those strong genetic risks and predispositions. But those individuals that have a moderate risk or a low risk, there are proactive strategies. And in some cases, progression can be delayed or even partially reversed. And a lot of scientists' recent research has shown this. It is possible, just like Pia had the example.
Can I just comment on that?
Yeah, please.
Yeah, you're absolutely right on that. But I would like to add that those who have a high genetic risk, they can really not do anything else than like lifestyle changes. So if you have a high genetic risk and you also drink excessive alcohol and smoke and don't exercise and so on, then you can at least modify those things and get something positive for your global brain health.
And with our colleagues, we have this humorous thing we say that what you can do, you can build your towers. If you have towers, then you have something to, demolish. If you don't have any towers, it's demolished already.
Janika, from memory point of view.
Yeah, I was thinking about patient relatives, talking about secondary and tertiary prevention. We have to include the relatives, and we can do very few if the relatives haven't get any education and information about disease and lifestyle changes and things like that. And in my work at Memory Clinic, I have many times used the brain bank metaphor that preventing dementia is like building up a savings account for your brain. Every time you exercise, eat well, sleep properly, or learn something new, you are making a deposit. But poor habits like smoking, isolation, or unmanaged health conditions act like withdrawals. If you build up enough cognitive reserve, you can afford some losses later without going bankrupt. And this brain bank idea, the goal is not to never spend, but to have enough in the bank when the expenses come.
Okay, so, yeah.
I just wanted to add something. A lot of those risk factors we already know when we're talking about, but just yesterday, I came across a research from Harvard Medical School from CNN Health, highlighting lithium's potential in Alzheimer prevention. And this is particularly interesting. Okay, I don't want to go into the science, but as we're talking about healthy eating, and it comes to this, that the lithium, the microdoses of lithium are so important, and they're in the food. And they said that leafy greens, legumes, nuts, and spices like turmeric and cumin had much of those this lithium. So we already see them in this prevention nutrition schemes. And now we're wondering whether it's the lithium that's actually helping our patients. And the bottom line of this story is that we're not done yet. It's not just, we're just starting the research. We're just finding out all of the risks and different things we can modify. But maybe all of those things that we already know, we will have scientific proof, like this lithium with the microglia and how it gets the amyloid from the brain. Broad terms, but basically I think those lifestyle changes will be backed up with very good science in upcoming years, and then we will have more impact in why we are doing this.
Thank you for coming to the science, because now we can say that in Finland, the Finnish finger model study that came out already 10 years ago, there is a proof that multimodal action can prevent cognitive decline. Pia, as you are from Nordic, could you share some learnings or experience as it, how this science has put into the real life or real actions?
Yeah, I think that the finger model is, as it says, a model that can be used, and it is also very applicable to use in municipalities and daycare centers and also in just in your ordinary life. The finger study was done on in high-risk persons that were of age 62 to 77, I think, or 60 to 77. So it's quite late in life when they started this lifestyle intervention with physical activity, healthy food, cognitive training, social interaction, and what is it? It's monitoring the blood pressure and the high cholesterol. And they got really good results from this study, and there has also been follow-up studies in this intervention group. But one thing that also was so clear is this about the feasibility, because there was a really low dropout rate in this study. And that means that this can actually be done in everyday life or in healthcare centers and so on. So this is used on a broad scale in Finland. And the Sanna Marin government also introduced the Finnish elderly program, and now it's changed a bit, but that has also mentioned the finger model on a prevention or a policy level. And just recently, the Swedish government launched a new dementia strategy in Sweden. And their prevention and the finger model is also included in that strategy. And that is, of course, also for high-risk persons. But this doesn't require a lot. Of course, it requires organization and so on, but it's kind of basic things to do with these interventions. But one thing that I would like to point out is that we should need to monitor high blood pressure much earlier in life, and it should be like a low threshold thing to do, to go and monitor your blood pressure so that you can actually lower it if it's too high already early in your mid-ages. So this is something that could still be done, that isn't the finger model, but it's a part of the model, and it's also one of the risk factors, the Lancet risk factors. And of course also the high cholesterol that have shown that it's like 7% of the total prevention potential of 45%. So that's also something that should be feasible and easy to do, maybe once a year or once every second year or something like that. Yes.
Okay, thanks. I understood also from my network in the Alzheimer Europe that this finger has spread, and it's now over 70 countries in the world, and the different patient or population groups have been involved to see how this works. And it was for me kind of just science piece when I met a person from Iceland whose wife was diagnosed with young onset dementia at the age of 56, and he described how Iceland has incorporated this finger model to their daily care centers. Not just that at home you can take it, but it's a kind of governmental or state regulation that all daycare centers they have all over the Iceland, the finger model is used, and they are tracking the results. And the guy was really happy because his wife has been there now for 6 years, and the decline or the progression of the disease has slowed, so she can still live at home and live normal life as they wanted. So, but now.
Could I just comment, because I forgot about Iceland, because they have also had in their dementia strategy for quite a time now that they are pointing out prevention. So when they launched their first strategy, 2020, they included prevention. And I have also visited one of those daycare centers on Iceland. On our website, on Nordic Welfare Center's website, there is a really nice article from one of those daycare centers where the people going there are telling all the benefits and also the social interaction and so on. So Iceland is also on track.
Okay, there is evidence and there are good models in the world. So what can we do? Here is the stone, and who should do? Is it the personal responsibility to take care of themselves, to make the brain health kind of priority? Is it the healthcare providers or policy makers or politicians? So where to start and with what to make this happen also in Estonia?
It is a very good question because I'm a practical man, and I say that what we do miss in Estonia is geriatrics. And I have, in those last 2 years when I came back from Germany, I have actually situated a geriatric day clinic in Pärnu. But the point is, what I want to tell you, I'm a practical man. You know,
good. We like practical.
There is something when we talk about lifestyle and everything, and we say, yes, you won't have prostate cancer, you won't have cardiovascular disease. But Germany has a very high level of geriatric knowledge. And what in Germany is very special, elderly people and music. It starts with the people who are singing in the group. It is dancing, it is making balls around the floor within the music. And it is the concept of multitasking, which I would add to lifestyle. And in those geriatric settings, say people over 70 who were alone at home, and we had a kind of depression, and that depression is also always, as you told it, connected to cognitive decline. Music, dancing activities, singing is something special we should actually provide for our communities, because there is a lot of work has been done already. I have lectures about 10 communities about my book, and really they have got funding from European Union to provide activities and to provide special events for elderly people. And I was very glad, for example, in Võhma, there were 3 people who came to sing, and the whole lecturing hall started singing. And I think we should not forget that geriatrics has some special tricks. Not only the prevention and not only publishing the books about, if you don't drink alcohol, there are someone who's drinking alcohol, who was also had cognitive decline. But when he started dancing, he was better after it.
Okay, it's a finger from finger model. Social activities should last till the end of the life.
Yes.
And who should provide? Communities?
It is a very tricky question because the healthcare fund is not ready. As you know, they don't have money for geriatrics. They start geriatric activities in 27. We had just a discussion on the university clinics. But the community has now funding over the social ministry for activities of elderly people. And when somebody would ask me what to do, please make at least 20 minutes of music during those
meetings.
meetings.
Thank you. Very practical.
Or if we can take it broader, maybe us as a society can do something about it. It's like the kindness doesn't cost a thing. We don't live in Anton Hans and Damsare times anymore, where we have to be in a quarrel with the neighbors and we have to see who's doing better and who's feeling bitter. So this stress is one of those things that actually affects people that much and the brain that much, because the hormones that come with the stress are actually a major factor that's bringing us closer to dementia. So the first thing we can do is be kind and see good in people, interact with people, not because someone's better or getting something from them, but actually, just getting those positive vibes going on. Then
You're
we can
always
take
kind to your dancing partner.
Yes, and that's absolutely true with the music, because the social interaction is also, the research has proved that talking to another person stimulates your brain synapses. So therefore, you don't lose them because you use them much, because you have to use more of your brain to be in an interaction with another person than with a computer or a laptop or whatever. So I think this is the first thing we can do as a society, and then we can go to this. I'm really pro to this, that geriatrics, the deficiency of geriatric beds in Estonia is a huge problem, because those those patients living with dementia that I come across with are very often 10, 15, 20 years untreated for those main chronic diseases that could be prevented. And if it could have been done before, they wouldn't be in this state. So this is the state for, but the other thing is what we all can do.
Okay.
Talking about kindness, we have done a lot about with those support groups for relatives with relatives of people with dementia. We have over 30 or even over 40 support group going on in Estonia, and those who are interested can join. But my worry is about how to reach to the future relatives. We have reached almost all their relatives for people who has dementia at the moment. But talking about near future, how to reach to them. Chris, what do you think?
I would ask from Pia that definitely you have experiences in this awareness campaigns and going public with the knowledge. How much this will impact, or does it have any impact, or is it more important to have those personal relationships than to just have a nice awareness campaigns that are lasting, let's say, 2 weeks in a year and then again next year? So campaigns. And the other question I put into the air, just maybe for the next round, that should we include this brain health topic into our national health developmental campaigns or well-being campaigns or policies? Because as you all know, Estonia is lacking dementia, national dementia strategy, and I guess it will not be, because there are already so many different strategies and plans. So
just comment on the discussion we have had here, because I think you are absolutely right. This is about having fun, having a good life, and making new friends also when you are older. And this can be made in singing in choirs or dancing and art groups or anything. And I also think that this is the key takeaway from Aarhus municipality or Reykjavik daycare centers, or that people are having fun and they are doing new friends. And they are making new friends with people that have the same disease as you in an early stage, so they can also laugh about that. But then I would also like to emphasize if we are talking about primary prevention, and that can be done late in life before you have dementia, if you are going to get it, then we're talking about healthy aging, and there is a network of healthy aging communities in the Nordics that are really emphasizing on healthy environment, breaking social isolation, and so on. And of course, I would also like to highlight one municipality in Sweden called Bjuvs kommun. And they are actually giving dancing classes to all their citizens over 65 years of age. They are having senior discos. Yeah. And they have like bus trips and do things. So that municipality has really focused on the health promoting activities. And talking about awareness, of course, this is an important topic because this brings also hope that you can be aware of, that there is some things that you can do. But from a society perspective, we also need to have good policies, for instance, because this starts early in life. So I think that having good policies on, for instance, smoking for young people is important. And then we need to focus on the right things in geriatrics, like breaking social isolation and giving hearing aids and so on. So this is a life course thing. And it sounds really dry when you talk about risk factors. But the thing is that you can have a really good life combining the cognitive stimulation and social interaction and physical activity and eating good food. So,
Yeah.
yeah.
Yeah, as a conclusion, it seems that there is never too early or never too late. So you can start with the primary prevention, having the good healthy lifestyle, and also during the already disease course, you need to have the same lifestyle. But just reflecting back that we have also, I think, quite good activities and possibilities for elderly people to have the social life. But whenever it comes to the patient already with the diagnosis or some, cognitive decline, memory issues, then somehow these people, the groups and fun activities for these people are closing. So, and I'm now thinking that should we make more activities or possibilities to be active for the patients, or should we integrate them to the general activities? Again, from my own experience, when my mother got the diagnosis and it was seen that she can't be at home alone the whole day, I started to look for the possibility to these day centers for the elderly people. But whenever we came to the point that she has some challenges with the memory, all the doors were closed. The only possibility was daycare center or daycare, where they actually the whole 6 hours were cutting the pieces of papers and gluing them to the other paper. So on the third day she said she will not go there because, this didn't support really this cognitive training or keeping up her brain health in that sense. So just the last question, and then we can go to the audience for their questions, comments. How we can make the people already with cognitive decline or memory problems, also dementia diagnosis, into the centers that is meant for the elderly people. silent.
Maybe we should include children.
Yeah. Okay, I will give you some time for thinking. Do we have questions from the audience or comments or ideas? Yeah, there is one. Yeah.
If there is any specific difference between physical interactions and let's say more nowadays with this computer, internet, you also have this online interactions. Is there studies about this topic or not? Like, for example, apps like Clubhouse or others, people even become friends, they talk to each other a lot of... thank you very much.
Maybe Jaak also knows about this. I don't have an article to refer to, but as I understand, in a social context, people have to observe so much more triggers. So the brain is so much more active talking to an actual person in front of them, because it's not just the face or the voice, it's the body movements and everything. So there is reciprocal action going on, and this stimulates the brain more.
My experience is I was working in Berlin for 8 years, and then in a smaller town, it is absolutely different because when you are in Berlin and you have to communicate and you have to have a logistic in your head, how you could get to your friends when the U-Bahn is closed, and it is totally different. You don't even look for internet or something. But if you are in a small town and there I have seen elderly people who have been looking actively for contacts over internet, but German literature, to my best knowledge, has no publications about that or any evidence-based materials.
Hello, thank you for a talk. A question regarding how could we notice the cognitive decline in our relatives or close people or in ourselves? What would be the first signs if it's not your name or face? Or it sounds like this will be too far already.
I don't know, maybe Jaak. Or the main thing I see that a patient that has a very deep cognitive decline already, and a lot of the relatives, they don't see it at all, because the people are in their home environment, they're doing the same things that they've done for 10, 20 years. I've had a patient with a very serious cognitive decline, but she still went every other week to the manicure and got the pedicure, and it's a small town. She knew how to walk just there and back because she had been doing this for 25 years. And no one realized that the decline is so bad. So basically, as we're talking about Alzheimer's, and the ability to learn new things is very deficient. The old things stay in mind for a long time. So you actually see how does the brain work when you put someone in a new position and they have to do something new that requires them to think ahead, to plan ahead, or do something. So this is the way, if you put your elderly in a new situation or in a new interaction, in a new place, then you actually see the possibilities of the cognitive problems. The most easiest, I guess, because a lot of people think about cognitive decline only about memory, but it's not about memory. There's amnestic, non-amnestic, and multi-syndromal dementias. So this is the main fault. No, her memory is fine, but she can't handle things at home. So it's the situations and the things that people have to do. There you see it.
I would add a little picture. If we think about mental universe, and I think it has not been described very well in Estonian literature. Mental universe is not memory, it's not only emotions, it is the life, what you will, how are your social contacts, how do you perceive yourself and your neighbors, what is your sleeping time. And mental universe, according, now I tell you one figure which is very important, according to the Arbeitsgemeinschaft für Methodik psychiatrische Krankheiten. Das ist 60 years old, and we can describe mental sphere with 122 different components. And I think it is the one way, if we are talking about elderly people, we say they are not just they were. We want to describe, don't they want anything more? Or are they aggressive? Or what is their memory problem? Or have they lost the ability to make fire in the stove and make it before the stove, in front of the stove? And everybody who has to do with people who are mentally, say, not very normal to my own perception, then you should try to describe the syndromes or the little facts what they have within this big mental universe. Do you agree me? Good.
As a young person? Well, as a potential dementia patient in the future, the main thing is to actually look at all the risk factors and minimize them as much as you can. And with that, probably there is a possibility that dementia won't come.
Could I also just comment on your question? Because this is something that has been stressed very much in the Nordics, that you need to find dementia early, and you need to lower stigma so that persons actually seek help if they are worried. And Norway had a big awareness campaign on TV where they informed the public. And then later on, they realized that they should have informed the doctors and the nurses first, because people came and the healthcare personnel said, no, that's no problem. You don't have any problems, without even doing tests and so on. So I think that it's very important that if you're worried and you want some help, that there is also this an awareness in healthcare. And I think that you, that are professionals, also can tell someone who is young and forgetting names and places and meetings that, hey, you're probably exhausted, because that affects also the brain. So if you don't give the basics to the brain, it can be exhausted. Or
Well, yeah, it's just that you have to stay physically active, stick with a brain-healthy diet, stop smoking, maintain a healthy weight, stay socially active, stay mentally active, get more quality sleep, limit alcohol consumption, and protect your head, all means.
Thank you. Yeah.
Hi, thank you for the good discussion. You mentioned before that when a person has a dementia, the usual activities that are meant for elderly, the doors get shut and they're not kind of welcome anymore. So how do we educate or spread the knowledge to the elderly who are active in their community so that they would not push out these people? Because I also work in a welfare center and have seen that when a person gets dementia and acts really weird for them, they get mad and angry for that they're speaking stupid things or whatever, and don't meet their expectations. So how do we reach these people? Because we also ourselves learn still a lot about dementia, but for them they also don't know, so the easier for them is to push out these people. So do you have some good practices or experiences, or how do we make them more tolerate this and more welcoming, the people with dementia? Thank you.
who wants to take my opinion is this the awareness among, as you started, healthcare professional and the general public, and diminishing the stigma and that dementia is not a normal part of aging, it's still a disease. And we have to recognize those people as a person with a disease, not that, and they are not guilty because of that, you know. This is understanding, being kind, and
Compassion,
being,
I think it is, because we're compassionate when a person has some kind of somatic disease. Then we understand that they're so sick. But often I see that with dementia patients, people are not compassionate.
I think the same, that normalizing that dementia is a disease like other diseases. For example, osteoarthritis. Many people of maybe our this local club for older people, they have osteoarthritis or cardiac disease. This is disease, and we can live with it. This disease, and dementia is also behind the dementia is just disease like the other diseases. There's no difference at this point.
Awareness campaigns, should we target like social centers and the groups of elderly who are going there together so that they could be more tolerated and more compassionate towards people with dementia and notice it? Because also from our experience is that they are also very often like a support person for another elderly who is living in solitude, and they don't know. So they just help what is needed, but they don't know how to ask for proper help from us, for example. They just help a neighbor and don't ask for more help that we could provide. I just mean that the awareness raising campaigns are mostly maybe targeted for like younger or people who have still parents who they should notice or like watch over and see and help when it's needed, but also the elderly who might have dementia one day or are the active part of the community and they're doing their whatever dance, singing lessons or handicraft work, whatever, but they don't have their experience with that, they don't have the knowledge, and they don't get the knowledge because they don't think it's something it's no, my memory is good, I'm living my daily life, it's good, and they don't notice it on their mates around them. And then they get pushed out because they started to act weird and they get in a fight or something. And then we have them divided by they care for people with dementia, and then the active elderly community who is dancing, singing, and going places, but they don't include people with dementia, which they could.
Well, I would like to comment on that because I think it's absolutely possible to include people with in the early stages of dementia. But of course, this is a progressing disease, and it's also often, unfortunately, also there are some can be violence towards persons with dementia, but also that the people with dementia can also be violent, and so I think that if it's like community-based centers that are driven mainly by the civil society, then I think that those with the early stages could be included, but then I think that you need to have tailored and knowledge-based activities and centers for people with more advanced dementia. And nothing says that you can't sing and dance and do things at those more advanced centers as well. You can do the same things, but then you need to have more skilled personnel that knows dementia and the features of dementia. So I don't know what you say about
I think
this.
one of the things is also that, because there's so many different dementias and they affect different parts of the brain. So I've seen patients that with a very low mini mental count, so like deeply demented, but playing chess. So there could be something that those patients still know. There's some part of the brain that works, and you can use that. And find those things that they can do. And also with those patients, I've seen that like a classic Alzheimer patient sitting at home, she doesn't know maybe just how to switch the TV on and the light, so she keeps just sitting there. But if you put her in a situation where there's people around, I don't know, singing or doing something, take them with you to a gathering, they seem to enjoy themselves, although they can't initiate anything. And this is the apathy, which is one of the symptoms of the disease. You can take action in this way, putting them into situations where the brain works, or putting them doing things that their brain still knows.
Any
Thank you.
experiences from Germany integrating patients with not diagnosed yet?
Yeah, still, the question is, I would may I make another comment in this moment. I see actually a major breakthrough in the recognizing dementia and mental disorders, and that will be brought by artificial intelligence. I'm sure that if we get used that artificial intelligence does know something more than a common person, and when the daughter of a mother who's 80 years old and was starting doing not so common things, does not want anything, or are emotional, or has a bit paranoia that somebody is stealing her money, and if you give those symptoms one after another to the artificial intelligence, which will be trained for such cases in some years, I see a major breakthrough. It is not the booklets that we publish and we think that many people will be reading them, but it is the personal usage of computers, and they know, yes, my dad or my uncle has that and that. I put those signs, what I have seen in the computer, and then is the breakthrough. Then we come to the point that not the case that artificial intelligence will will take care of them, but you pick those up and you print it out and you go to the psychiatrist, to the geriatrician, or the family doctor. I see a major breakthrough coming in a couple of years.
So meaning that the awareness among healthcare professional, educators, social workers, general public
and
is the key.
detailed diagnostics, because we are very general. We talk about the umbrella, yes, dementia, but as I told you, there are 122 signs of in the mental universe. Yeah. And if you put them down in the computer for artificial intelligence, it can make for you proposal, and you can show this proposal to your family doctor, to the psychiatrist, or to the geriatrician.
But if the family doctor is not aware and still believes that dementia is normal part of aging.
It's family doctor's problem, it's not my
Okay,
problem.
good, so it's education. And the second, that I have to have some knowledge to put the right things into the AI.
No. Artificial intelligence will guide you. There will be a chapter. I have some disorders or some peculiarities with my parents, and you start to describe them. It is you don't need anything more. You just have to say, this is the topic I want to talk to you, dear partner, artificial intelligence.
Okay, good. This is for relatives. Now, just it reminds me the book Still Alice, of movie was also created, and I think there is a really good point how this Alzheimer makes your starts to work somehow against you when Alice had a list of 3 things. And if she can't answer to these things, she needs to go to the bedroom and take the box of pills that she had prepared to end this story. But unfortunately, when the day came, she couldn't remember when she went up to the bedroom why she is there. So it didn't work for him. I just kind of, maybe it's an artificial connection, but when it comes to AI, I can't maybe.
It's not for the patient. It is actually not for the patient, because a patient who has memory disorders cannot describe his syndromes to the artificial intelligence. It's still for relatives and the neighbors and so on.
Yeah, okay, good. Unfortunately, I see that our time is coming to the end, although we could talk about this, I think, for longer. So as a final comment, as now we know, I hope we also convinced you that there are things that we can do and we should do to prevent still dementia or prolong stop the progression or delay the onset. So how can we make this dementia prevention as a common goal in Estonia, or is it needed at all?
Yes, we need it.
But how? Where we should start? Still from the campaigns, or wait until AI comes to support us?
Start from a young age, start from school, and overall these state educational programs include brain health into those programs, I think.
Thank you.
What I can do, I can propagate that geriatrics must be a part of Estonian medical system, and over geriatrics there is a very, very big area common with geriatrics, dementia and psychiatrics has a very good stand in Estonia, but I think what I can do personally is to make everything that there will be open the geriatric department in the university clinics 2027.
Good, very, how to say, very practical and
I'm always practical, always practical.
Touchable point, thank you. Pia.
Yes, I don't know, but I would suggest that you get a public health strategy, like an overall public health strategy, where the politicians lines out what has to be done, and that is in a life course perspective. Because from the 14 risk factors, the main part actually hits mid-ages. Mm-hmm. So when you are between 30 and 55, somewhere there. And it includes also like obesity and smoking and so on. And for the youngest, it's the schooling system, but you have a good schooling system in Estonia. And for the late life, look into the social isolation part. And I think also that a good dementia strategy also is very valuable for late life and for those who are in risk of dementia, because that lines out what has to be done from society for this group of persons.
Mm. Then the strategy should come with the budget.
I think the good points have all been said, but the critical point here is right now. Our emergency rooms are full of those people that don't have a place to go. And the relatives can't really handle them anymore. And we could start from there to making those places that they can go peacefully, that have those interactions, that milder their symptoms. Right now, they are the ones that no one wants. Mm-hmm. And we have to get those places ready for them to go to. And then when we have that, then we reduce the stigma, see it's okay, and then we can go backwards teaching the midlife how to get better, and then the kids as well.
Good, thanks. And I think this is a good point for ending the discussion and giving me the, how to say this, the support and meaning of my work in NGO, that these persons need to support, they need to be visualized, and they need to be visualized in a positive way, because the number of people who would need our help will increase. Either we want it or we don't want it. So thank you all for coming. Thank you for our panelists. Thanks for this fruitful discussion, and I got, at least for me, many points to move on to fight for the rights. And for you all, so just remind, it's never too early, it's never too late to start the prevention of dementia. Thank you.